Thank you very much. Well, I begin today by acknowledging the traditional custodians of the various lands on which we meet. In my case, it's the people of the Adelaide Plains, but we're meeting all around Australia. I pay my respects to their elders past and present and emerging, and I extend my respect to the Aboriginal and Torres Strait Islander peoples who are meeting with us today. So welcome to our Sax members and thank you for joining us for the 2023 colloquium. We value all the opportunities we get in meeting with our members, and this annual colloquium is one of them. Just a couple of housekeeping announcements. First of all, for questions after we've had the presentations, please use the chat function, and Martin, who'll be moderating the session, will be able to retrieve the questions from there. And please do note that the meeting is being recorded. So I'm going to pass over to our CEO, Martin McNamara, now to give us some of the highlights for the Sax Institute in this past year. Thank you, Martin.
Thanks, Ian. I'll just try and share my screen and see if that works okay. People should see a slide deck saying Sax Colloquium on it. Is that right?
Yep.
Great. So that should be the second slide saying overview. Is it, Hannah, can you see that second? Yeah, okay.
Yes.
So thanks for the introduction, Anna. I just wanted to go through a couple of things that have been happening at the Sax Institute in the last 12 months or so. A short update on some of the work we've been doing internally, some of the new tools and assets and initiatives we've been working on. I want to talk a little bit about the financial outcomes of the year, and today is also the launch of our annual report, and it's a fantastic report in and of itself. So those of you who are interested, I encourage you to have a look at that annual report, and I'll give you a link to that later on in my presentation. So the first thing to say is the last 12 months or 18 months actually has been a big planning phase for the Institute. There's lots of detail on this slide. I don't expect you to read it all. This will be available on our website. But just to say, we now have set up our strategic plan for the next 5 years, and I think it's going to be a really important period for the Institute and an important period of growth. Lots of exciting things planned. I think we do want to be more visible around promoting the use of credible evidence. We do want to have a role in driving innovation and looking at the capabilities in the system to use evidence. And then, of course, we're going to be looking at maximising the impact of what we do across time. So those are the big objectives we have. Those of you who are interested in learning more, all of this strategic plan will be on our website, and I encourage you to have a look. So in terms of the last 12 months, we continue to have lots of interaction with our members. We have now got over 74 members across the country. Some of the members that joined in the last 12 months include the Southern Cross University, the Australian Centre for Health Services Innovation, the School of Nursing at the University of Sydney, and the Global Obesity Centre at Deakin. And we've got a raft of new applications for membership coming in all the time. So if people in your networks are interested in becoming members of the Institute, I do encourage you to reach out to us. It's a very important network for us, and we're very keen to expand that membership group. We have been focused in the last 12 months or so on some work that started in 2022 on measuring the impact of health services research. That's looking at the impact of the health services research community over the last 10 to 15 years. There'll be some important outputs of that work being released early in 2024. And it's been a really interesting process working with lots of our member organisations to tease out some of the impacts of that particular research agenda over recent years. We also had a really highly valued forum this year where John Lavis from McMaster's in Canada presented on the Global Commission on Evidence work that he's been leading. And for those of you that weren't able to join us at that forum, there's a lot of information on our website about the work of the Global Commission and some of the tools and techniques that John and the broader network involved in that work have developed in recent times to maximise the use of evidence in decision making. So encourage anyone who's interested in that to have a look at our website for more information. So the last 12 months, we've got a raft of new initiatives happening across the Institute. I won't go through them all, but one of the things I do wanted to flag that we've been going through quite an extensive process of building on the 15-year partnership we've got with Aboriginal communities to create a Centre for Aboriginal Health. It's largely going to focus on things like evaluation and implementation. There'll be more to say about that centre in coming months, but a really exciting development that's builds on the history of work in that area. We're also at a really important phase for the Australian Prevention Partnership Centre, and some of you would know about the decade of work that's gone into the creation of that Prevention Partnership Centre. We're entering into a new phase, and the network of research partners that are involved in that work will be really important to us. And if any of you are interested in becoming involved in that work, then do reach out and let us know. The other initiative that I think is of interest to the membership network is the journal that we manage, Public Health Research and Practice. We went through the process of this year of determining an impact factor for that journal, and it came out at 4.4, which is a really great score for a journal that's undergone a lot of development in recent years. And I encourage you to also have a look at that journal if you're interested in reaching a policy audience in your work. So moving on to some of the new tools we've been working on at the Institute, we do have significant capacity in systems modelling, and there's been a lot of fundamental work done in modelling the mental health systems in Australia, and also developing some digital representations of hospitals through a modelling approach as well. Some important work that I think will be rolled out further in the next 12 months. We've also got some new tools that we're badging as policy impact labs, particularly at the moment focused on things like ageing and end-of-life care. But the main intention there is to bring together the evidence base along with lots of stakeholders and people with life experience in these issues to come together to develop policy together. We've also continued to develop some of our key assets. Some of you would be aware of these already. We've got a secure platform for the use of sensitive data called Shore. That's developed some new capabilities in the last 12 months, particularly around the use of machine learning techniques within that environment. And we've got some new data custodian partnerships that really allow researchers to get access to data more quickly through that partnership model. And in 45 and up, we've created some new enduring linkages that mean that researchers can get access to data much more quickly than they would have been able to before by having that linkage in place across a number of different data sets. So some new assets that have been developed in the last little while that I think have got real value to our membership network. And then finally, I just wanted to share with you some of the financial outcomes for the 22-23 year. So you note that the 22-23 year, we had a planned deficit. That was to support some innovations that I've just been through, some of them actually, but some innovation work that we've had underway at the Institute, particularly in the Shore platform and in 45 and up. So we've made some important gains in those areas. And we expect those investments that we've made are going to show important dividends in future years. And I think they're setting us up well, and in fact, the research community up well to benefit from those. And our net assets and cash balances remain strong as well. So just to flag, that's where we're at from a financial perspective. And the last thing I wanted to flag before I throw back to Ian is today is the launch of our annual report. I think it's a really compelling story about what the Sax Institute's achieved in the 22-23 financial year. For those of you who are interested, the link's there, and many of you will receive this through various networks you're already involved in as part of working with the Institute. So I might stop there, Ian, and throw back to you for the next part of the session. Ian, you're on mute at the moment, Ian.
Here we are. It now gives me great pleasure to introduce our three speakers who are going to present at the colloquium. They'll speak for about 10 minutes each, and we'll have the questions in a session after each of the speakers, after the three speakers have spoken. So first of all is Adjunct Professor Ruth Stewart, who's the National Rural Health Commissioner. She was in fact appointed as the second National Rural Health Commissioner for Australia back in July 2020, and she brings a background of 30 years as a rural generalist doctor with advanced skills as a GP obstetrician. She and her husband now live and work in Roma, Maranoa, located in southwest region of Queensland, but for 22 years they were practitioners in private practice in Camperdown, southwest Victoria. And Ruth in 2008 was the inaugural director of the clinical training rural program with the new Deakin University, so she got to establish that rural program, and it included 18 longitudinal integrated clerkship placements for third-year medical students, where they spent their core clinical year in rural practice. In 2012, Dr. Stewart moved to the North Queensland to become Associate Professor of Rural Medicine and the Director of Rural Clinical Training with James Cook University, where she's overseen a doubling of rural clinical placements for the medical school, and she's also worked at a senior medical officer at Mareeba Hospital. She's past president of the Australian College of Rural and Remote Medicine. She was on the board of the Torres Cape Hospital and Health Service for 6 years, the Cape York Hospital Board for 2 years, and has been on the board of several regional training organisations for general practice. She's been on the board of the Rural Doctors Association of Australia and the Tropical Australian Academic Health Centre. Her particular interest, she received a PhD from Flinders. Her thesis examined the lessons learnt from a managed clinical network of rural maternity services in southwest Victoria, and she has a long-standing interest in rural maternity services and particularly sustainable models of rural healthcare. So welcome, Ruth, and we look forward to your presentation. Our next speaker is Brendan Cutmore. He's the Director of Information and Performance Support at the New South Wales Regional Health Division of New South Wales Health. He, prior to this appointment, was Executive Director of Aboriginal Health and Wellbeing for Western Sydney, New South Wales Local Health District. And as the Director of Aboriginal Health and Wellbeing, he focused on helping transform the organisation's services, creating, in fact, a whole system of health promotion and prevention that made a difference to the lives of not only the 280,000 people across their communities, but making meaningful gains in the health of over 30,000 Aboriginal people in the region. He uses his personal experience to shape not only the types of services New South Wales Health provides, but also policy designs made in partnership with Aboriginal people. And our third speaker is Dr. Jan Gissard, the Director of Knowledge Mobilisation at the Regional Doctors Network. Jan started his career in academia at Charles Sturt University in Orange, New South Wales in 2007, where he was involved in the design and delivery of agricultural and horticultural programs. He subsequently managed the curriculum and the professional accreditation of complex health courses, including medical laboratory science, pharmacy, paramedicine, dentistry and medicine, and he remains as an adjunct appointment. In terms of his work at the Rural Doctors Network, the Directorate is tasked with generating original evidence and aggregating the existing data to generate and translate knowledge that supports the strategic vision of the organisation. So in addition to the sources that are publicly available, these data are acquired using valuable and ongoing collaborations with both patients, professionals, as well as communities and representatives of the health-related sectors. The contemporary rural health workforce challenges faced by these stakeholders represent a significant complex system and require novel approaches combining multiple research disciplines. And indeed, Jan has an evaluative mindset and uses mixed methods research to support causal claims and create robust evaluative judgments, which are always needed for the political business of forwarding this sort of work. The purpose of the work is to create usable knowledge, to inform policymakers, and subsequently design and evaluate solutions that increase patient access to not only a high quality health workforce, but of course a sustainable workforce. So I'd like to again thank all the speakers for contributing to this, and I just have to say that the topic was one that was suggested at last year's colloquium of being of interest to our members. So I'd like to hand over first to Ruth for her presentation. Thanks, Ruth.
Thanks very much, Anne. So let's see how I go with this. Sharing the screen. bear with me while there we go. Can someone tell me when you can see the whole screen?
That's great. Thanks, Ruth.
Yep.
Okay, thank you. So, hi, I'm Ruth Stewart, and I'm going to talk today about giving authority to the rural voice. I'll begin by acknowledging the traditional custodians of the land on which we meet today. I am on Mandindangi land in southwest Queensland, and I pay my respects to the elders of this land and waterways, past and present. I'd also like to acknowledge emerging leaders within our communities. I extend my respect to all Aboriginal and Torres Strait Islander people who are with us today. So I'm going to talk to you about rural generalists, about progress on rural health matters, about community co-design and co-development, and geographic narcissism. So let's start with the rural generalists. What is a rural generalist? Well, I'm going to refer to the Colin Grove Agreement between the RACGP, the Australian College of Rural and Remote Medicine, and the Office of the National Rural Health Commissioner. I was not Rural Health Commissioner at the time that this was forged, but I was president of ACRM, so I was deeply involved in this. So a rural generalist is a medical practitioner who is trained to meet the specific current and future health needs of Australian rural and remote communities in a cost-effective way by providing both comprehensive general practice and emergency care and required components of other medical specialty care in a hospital and community setting as part of the rural healthcare team. So in my work, I am very much involved in consideration of rural generalism, both in medicine, nursing, and in allied health. A rural generalist, you can really think of them as a Swiss Army knife of health professionals. They have they provide you with the basic tools to get most jobs done. But if you were trying to do a specialist job, you wouldn't use a rural generalist. The Department of Health in their National Medical Workforce Strategy, which was published in 2021, had this phrase that the ageing population and growth in multimorbidities and geographic challenges require more GPs and more generalist doctors. Medical leaders need to recognise that a broad scope of practice is intellectually challenging and fulfilling for individuals. With that statement, they were taking head on the growing assumption, which has been developing really over the last 50 years, that clever doctors are specialists and non-specialists are the non-clever doctors. Our problem is that the Australian health system and those health systems that provide the most robust system of keeping a community well rely very much on generalist doctors, general practitioners in Australia, and primary health care. So, don't quite know what happened there. It turns out that those GPs working in remote settings are more likely to recommend general practice as a career than those working in major cities. So it seems that scope of practice of rural generalism is actually very appealing. Yeah, 51% of doctors in remote settings practicing that broad scope of practice recommend their career to others, compared with only 36% in major cities. We have been making quite significant progress on rural health matters in Australia. So let's think. This year in August, my office sponsored a special supplement to the Medical Journal of Australia, reflecting on the 25 years of the Rural Health Multidisciplinary Training Program and what we've learnt about what works to educate and develop a rural workforce. We know what to do, we're just not doing enough of it. So we now know that 46% of the 18,000 Australian doctors in training are interested in rural practice. That's huge. Our problem is translating that interest into bums on seats in rural clinics. So there's also a growing interest in rural generalism. 13% of new Australian graduates want to be GPs, but 6% on top of that want to be rural generalists. And general practice, with those two added together, is the second most preferred specialty of future practice for new graduates. That still only adds up to a bit under 20%. We need 50% or more of Australian graduates to want to be GPs. The government and a succession of governments of different flavours has continued to invest in the Rural Health Multidisciplinary Training Program, which has had a number of very positive reviews and evaluations. And they also invest in the National Rural Generalist Pathway and the Allied Health Rural Generalist Pathway. Community co-design and co-development. I find myself talking about this a lot, but I want to share with you what we understand it to be. This is from the Victorian Government's publication upon this issue. Co-design brings citizens and stakeholders together to design new services and policies. When you co-design, you build confidence, consensus, ownership, leadership, accountability amongst stakeholders, and you also produce community-led services and policies. There are challenges with co-design though. It relies on people's availability, so it takes time. You've got to allow ample time for the collaboration. And these next 3 points all relate back to what the power dynamics are and make it obvious that the power dynamics within the co-design group must be very clearly addressed right from the outset. So if you have groups of experts working within the co-design process, they struggle to achieve participatory mindsets. You've got to help them to do that. And in fact, co-design will fail if inclusion strategies are not adopted. Sorry. And you may not get consensus in large groups, especially if the experts dominate the process. So you have to work out those power dynamics. So my office led a body of work to define what rural multidisciplinary health teams were. We brought together 70 people representing nearly as many organisations, and in a summit in Cairns last year. And we published this year the Ngayabah Gadan Coming Together Consensus Statement. Now, within that, in the person and community context, we talk about models of care must be co-designed and guided by and responsive to the local community, and they must have comprehensive consumer representation and cultural safety. Policy examples that refer to co-design are the Innovative Models of Care program. To gain one of those grants, you must be able to demonstrate that you have used co-design and co-development. I can't finish this talk without referring to geographic narcissism. Marlon Fours coined this term as a devaluation of rural knowledge, conventions and subjectivity, and a belief that urban reality is definitive. What does geographic narcissism look like in health design? Well, it's when it's assumed that the gold standard is urban design. and therefore that must be the gold standard in rural health design. How does that impact us in rural? Well, let's think about, so if you have complex funding systems designed for urban high-density populations and you're trying to run them in a rural town, imagine one privately self-employed rural physiotherapist who needs to access multiple funding streams such as Medicare, work cover, private health insurance, and other forms of training. Also, the assumption that best training equips doctors to work anywhere, and best training is city training. But city-trained doctors are ill-equipped to work in rural areas, and they rarely leave the city. How do we counter geographic narcissism? Well, we have informed self-determination. That's vital for effective and sustainable rural and remote healthcare. Communities must be supported, engaged, and they must understand the impact of their co-design decisions. Cultural safety for all involved in the co-design process is paramount, and it requires urban health policymakers and health executives to share power with rural and remote communities. There lies the challenge. Okay, key messages. Rural and remote communities need a rural generalist health workforce and investment in generalist training. We have positive signs from the investment in rural training pathways. We are fostering rural intent. It's possible, but it needs to be scaled. And rural clinicians need organisational support and mentors to do research. But co-design is only effective when we have genuine collaboration built from strong, continuing relationships. So really, authorising the rural voice is the antithesis to geographic narcissism. Thank you. I've used up my time.
Thank you. Yeah, thank you very much, Ruth. That was very insightful. And I think there'll be a number of questions relating to that, because there are a number of vexed issues in there about how to best provide services to rural patients and overcome the tyranny of distance and so on. So now we'll move on to Brendan Cutmore. So thanks for the presentation.
Thanks, Ian. And thanks very much, everyone, for inviting me to speak, although I feel a little bit funny saying thank you after you've asked me to speak after Ruth Stewart. So that's almost just like a punishment to have to follow someone as accomplished as Ruth. So, but thanks for having me here today. I'm here actually on behalf of my boss, Luke Sloan, who is the Deputy Secretary for Regional Health, and at the moment I'm just acting in his role whilst he's travelling around. On behalf of our team, I'd like to acknowledge that we're meeting on Aboriginal land and pay my respects to Elders past, present and future. And also as a part of acknowledgement, I'd like to take this quick opportunity to thank the Sax Institute for a piece of work that we've been doing with a couple of your staff on the scalability evaluation of the collaborative care model in New South Wales, a piece of work that the Rural Doctors Network, Primary Health Networks and local health districts have been working on. And I really want to commend in particular in front of this group, Alice and Melissa, who have been instrumental on that project for the quality of work that they've done and their insights that they've shared. It's been outstanding, and I really value the relationship that we've got with the Sax Institute. So just from a regional health division perspective and across regional New South Wales, so just quickly, as a division, we were established just under 2 years ago at the back end of the parliamentary inquiry into rural, regional and remote health services in New South Wales, with the responsibility for implementing 44 recommendations from that inquiry. What we've heard as we've travelled around and visited regional communities and spent time with people, not just inside of the four walls of the hospital, but community, people within the community and a whole range of key stakeholders that form what I would describe as the general health, contributors to the general health and wellbeing of communities. And they've been incredibly insightful in sharing with us what they see as really important, and focusing on things like strengthening the workforce in regional New South Wales, and innovative thinking about what that would look like and what's required in terms of how we strengthen our workforce in regional New South Wales. We had Dr. Stewart talk about, I think, generalism, so this ability for people to be able to practice across their scope, and the opportunity for people in regional New South Wales to really demonstrate their full skill capability. A lot of feedback has related to improving access to care. And I think that we're moving away from, as well, in terms of a health literacy perspective, this expectation, this perceived view that regional people want to have an RPA or a St Vincent's Hospital in their small country town. The reality is, in the conversations that we have with people that are very grounded in communities, what they want is to be able to understand the services that are available to them, and for those services to be easily accessible, and where possible for people to be able to receive care as close to home. Improving equity of health outcomes is really important, and showcasing regional innovation. So again, not to steal from Dr. Stewart's presentation, but this view that all the good ideas have to come from the city for it to be able to fix what might be perceived as the problems or challenges that we have in the country is just not true. The reality is that there are some wonderful program services that are delivered in regional New South Wales, and a part of the Regional Health Division's responsibility is to work with our strategic partners and communities to scale those programs up. Not trying to apply a one-size-fits-all to that, but to take the principles or the bones of those programs and services, share them with regional communities, and help people to be able to make their choices about how they might be able to adapt that to their community's needs. The other is around just engaging regional communities. This people not wanting to feel as though that they've been either abandoned or isolated or forgotten about, that they want regular communication and engagement with their health service and with health leaders. Just make sure this is working. So some of the things that we are doing and have been working really hard on in partnership with a number of key stakeholders, both internal and external to New South Wales Health, has been the development of the Regional Health Strategic Plan. And you'll see that the 6 focus areas relate back to some of the key themes from the parliamentary inquiry, but also though they relate to the New South Wales Future Health Strategy, and also to the really strong levels of feedback that we've received through quite a broad consultation process undertaken for the plan. So it probably will come as no surprise to people online that things like strengthening regional health workforce, enabling the better access to safe, high quality care, keeping people healthy, and where possible, trying to shift the focus from people thinking about health just being what's provided within inside of the 4 walls of the hospital, but how do we keep people healthy and well outside of hospital and in the home, keeping communities informed and expanding that integration of primary, community and hospital care. And of course, the last is around harnessing and evaluating innovation and supporting the sustainable health system. A couple of examples of pieces of work that have been happening is the scaling of the Rural Generalist Single Employer Pathway program. So Murrumbidgee Local Health District undertook a really amazing piece of work that's been now scaled up across the whole of the Commonwealth, and New South Wales have received up to 80 exempt training positions for us to be able to appoint across regional New South Wales. We've just completed a recruitment process for the first cohort of people, and I'm really looking forward to that first group starting coming up in February next year. It's been a real trial itself in terms of scaling a program like the Rural Generalist Single Employer Pathway from Murrumbidgee up across other local health districts, because as I'd sort of alluded to earlier on, one of the things that that we shouldn't take for granted is that just because it works well in one local health district doesn't necessarily mean that that it will meet the needs and expectations of others. And a big part of the work that we've been undertaking is to ensure that each of the local health districts and their primary care partners are able to really represent their own identity as this program is rolled out into their region. The increase to the isolated patients travel and accommodation assistance scheme, so that IPTAS program, and it's phenomenal, the increase in the access to that service and the difference that it actually makes to people in terms of some of the care and travel that people, some of the travel that people need to undertake to receive care. So we do know through feedback that the increase in the percentage for reimbursement and also the increase in the promotion of the program and in the background trying to make it more accessible in terms of how people access that funding has seen a significant increase in access to the program, and also will continue through the review and ongoing review of IPTAS to look at how we can make it more effective as we go on. The collaborative care program, and I don't want to steal from Jan because he might actually mention some of this in his presentation. The scaling of the 5 existing sites that RDN and the local health districts, primary health networks, etc., have been working on, and Aboriginal community controlled health services across the state. So taking those really 5 unique current collaborative care site models, sharing that information with other locations across regional New South Wales that we believe would benefit from adopting a collaborative care model in their communities to address some of their needs. We're working in the background. I've just come from a session at a community this morning, having a conversation about how it might be applied in their footprint. And I think at the heart of collaborative care, the most unique and amazing component of collaborative care, in my opinion, is this: is that the program focuses on taking the voice of consumers, community members, and ensuring that all of the key collective stakeholders develop a program or a service that meets the needs and expectations of the community voice. So really looking forward to seeing 5 new sites across the course of next year. We undertook a review of local health committees and have developed 5 new guiding principles for engaging with local health committees across regional New South Wales. Those principles have been implemented in each of the local health districts, respecting the focus or model needs of each of the local health districts and how they choose to implement those. But nevertheless, the expectations of the 5 guiding principles for engaging with local health committees of commitment to community, collaborative partnerships, the committee-led action, members or advocates for health communities, and a culture of learning and improvement sits at the heart of each of the models across regional New South Wales. We know that local health committees can be an incredibly positive voice for communities, and that they make a significant contribution as well in other ways to our health services. So that was an important piece of work. I'm conscious I might be going over time, so I'm going to skip through the mapping of charities and community groups, and I'll share this presentation after, but probably just an important piece to flag around just recognising the significant impact that that charities and community groups have on our health services, and we'll be doing some work on scoping and mapping and trying to increase the visibility and effectiveness of that space. The focus areas for 2024 for the Regional Health Division and our strategic partners will be on implementing the strategic objectives in the plan that I showed you earlier on. That continuing to build engagement with regional communities will be critically important, and so we will not do this from the perceived ivory tower or from an office somewhere in Sydney. This will be about us being like I am today here in Young, out in regional communities with people. Scaling the collaborative care program in partnership with the Rural Doctors Network, reviewing New South Wales Health's approach to non-emergency transport for health, and supporting the expansion of the rural generalist single employer model. So I might just leave the presentation at that, if that's okay, Ian, and I'll take questions later.
Good, thank you very much, Brendan. That's certainly a very comprehensive and ambitious strategic plan, so we look forward to watching it unfold over the decade. And now we'll move to our final speaker and ask Jan to give his presentation. I mean, I think a sustainable, high-quality health workforce is really a great goal, so thank you, Jan.
Thank you. And look, I'll have to split my head between the 2 screens here to keep looking at you as well as my presentation. So my name is Jan Giza. I'm the Director of Knowledge Mobilization at RDN. And okay, I would like to start by acknowledging the traditional owners of the land that I'm currently sitting on. I'm sitting on a Wabakal country, the land of the flat surface, with reference to Lake Macquarie. And I also acknowledged elders past, present, and emerging, and Indigenous people in the room today. This is a piece of work that really captures the essence of RDN. It is by Sarita Fielding, and it is called Malang, and it means together our soul, and it really actually captures. I mean, that's probably a strategic plan in a visual format. So today, the brief for me is to provide RDN's perspective on the current state of rural health in New South Wales in 2023, and just some future visions about what's coming from a policy perspective in 2024. I need to put this into context. The mission, the vision, sorry, of RDN is health access for all Australians, no matter where they live. This really captures what we do. We are all about health access. That's our business. That's what we do. But we hope that the work that we do is transferable, of course, and we actively active in that space. We are a value-based, evidence-based, and outcome-based organisation, very comfortable in all these dimensions in terms of planning, measuring, and evaluating these domains. And for those in the Teams meeting that want more detail, we actually have a sort of a report that we published that actually digs a little bit deeper than I will today. So my comments for 2023 are really split into the things that we really value. In terms of communities, we've always put communities at the front of what we do. In terms of communities, certainly the work that Professor Stewart, as well as her team, and in this IMOC, or Innovative Models of Care, has been very valuable for us. I point to the fact that we're talking here about place-based care. This is what we really focus on. But I think these principles, these concepts are on the up this year. This is not just about RDN, it's about the sector. Really want to push forward the value of the wraparound models of Aboriginal controlled health organisations. If there was to be an exemplar of social leadership, I think this is a very good one. And I'll come back on social leadership just in a second. Unfortunate, very broad statement stating the obvious, but really the further you drive away from a city, that still today the lower the health outcome for the community members. In terms of the workforce, again stating the obvious, we're still very short of the workforce needs, not just in GP but in other sectors as well. Looking forward to looking at the impact that end-to-end medical school programs, so Meridian Basin Meridian Medical School Network is going to have on the system. Still a little bit uncertain, but likely to be positive given the construct it's based on. Both our previous presenters have talked about the single employer model, just pointing that the New South Wales single employer model is a training model. So we'll come back to that in a second. Just things that are working perhaps a little less. There's a very significant amount of negative noise in the system at the moment. If you were 23 going through med school, why would you, listening to this noise, why would you choose to become a GP? And yet this is the area of greatest needs that we have. I just note that Richard has put a lot of effort in turning this, and we need this leadership. We need this leaders starting to talk positively about the career, not just about what doesn't work, but what works, or what's positive. Our PR places this year or next year will be somewhat unfilled. So there will be filled, of course, once in further run, but the original runs, which really represents the intent of the RPRs, yields very a number of unfilled places. That simply means that graduates do not want to go to regional hospitals for their PGR1. The locums, we talk about locums in just a second, so I'll come back to this, and really we're putting a lot of effort in trying to make the difference between the narrative that is associated with retaining the current workforce as opposed to the narrative that is associated with attracting and retaining the future workforce. It actually is two different psyches, they're not actually the same narratives. In the technology space, we've got some great exemplars of work in the telemedicine space. I think that's very positive. I can't help but note, after the geographic narcissism comment, that some of those models are rural to rural models of telemedicine. Some of these models are metro to rural, and some of those models are now starting to become rural to metro. So, so that's positive. Still a bit unsure about the remote supervision of GP registrars. We'll see how that pans out over time, and we still have some challenges in the medical integration, medical record integration. With regards to the sector, again, I think there are some real trials. There are some real, and not just talking about the alien work, I'm talking about other work from other organizations. There's some real good work being done around innovative models of place-based care. Obstetrics and mental health are really important priorities. We're starting to talk about them, and they will actually, no doubt, in my mind, occupy a lot of the narratives. So locums in the system, I just want to point out firstly that locums are desirable. That's the first thing. They have a place in the system, but they do not have a place as a workforce solution. The cost associated with locums is very high, and we now have this very extreme situation where PGY to leave the system to locum. So, and anecdotal evidence is that, so with caution, that they simply don't come back to training. So those are individuals that do not finish their training pathways. It'd be hard to argue that the rural health sector in particular would not benefit from the work that not-for-profits do, but it is actually a very difficult time for not-for-profits at the moment. And really, we still have some significant challenges around GP funding models. Bruce Church talked about it just a second ago with regards to attraction and retention and sustainable models. With regard to governance, my opinion is that we do have plenty of plans. We have a lot of plans in the system. That we have, and as Brendan was mentioning, we already have linkage between some of these plans. So the Inquiry, for example, and the New South Wales Rural Health Plan. So we do have evidence of alignment between various components of the guiding documents, but we do need a little bit more of that. I think there's again, thanks to your work, Ruth, there's a very significant amount of focus on multidisciplinary health teams, how to get there. We have guidance. I've noted that the document is being referred to far more often recently. I also think that we do have a significant number of livers in the system, so there is potential in the system. Perhaps I'm really reluctant to rush to the statement that we need more levers in the system. I'm not actually convinced the levers are fully optimized yet. I can't help but go back to the impact that large organizations, both at federal and state level, have on the system. There's an increasing blurring of the boundaries of the operations of each of these organizations, and really, I would strongly prefer that leadership leads toward leaderships adopts a social leadership framework rather than a traditional management versus leadership. With regards to policy challenges, firstly, I want to, so that was the brief, but my personal opinion is really, it's a bit of a catchphrase, but really, policy challenges are real opportunities. That's how we see them. And that's why I'm talking about levers. That's why I'm talking about plans. So it's not a negative narrative, those policy challenges. With regards to community, certainly place-based solutions are becoming integrated in far more, in an increasing number of policies, but I mean, both Richard and Brandon talked to it. The hard part is the working together part, the power part. This is really hard work. It's seldomly a policy concern. It's mentioned, but it's probably not expended. I'm afraid to point to the fact that we are actually starting to uncover some of the unintended outcome of the referendum, and we do have some, and there will be some lingering impact of the referendum which weren't actually planned for, perhaps not, and they're probably they probably relate to the health locus of control being taken away from these communities. With regards to workforce, we observe a number of flow-on impact, flow-on effects of one policy on another. One of the great examples really is the nursing incentives. We were working on the projects that relate to primary care nursing placements when the incentive for tertiary-based or hospital-based incentives were announced, and suddenly the interest in primary care nursing just absolutely dropped. So we do have this sort of a flow-on impact, unintended flow-on impact. The other thing is we talked about RGs, but there are 13 ASTs, so specialties in RGs. The 4 most talked about are the procedural ASTs. That there's very good reasons for that because they occur in hospitals. There's a framework to support these ASTs, but there are other ASTs, including mental health and pediatrics, that are also on the list of needs based on the list of needs, but they are far more difficult to implement. We talk often about the replacement rate of GPs. It is not 1-to-1, we know that, but in doing so, so if it's 1 to 3, for example, we focus on those 3 incoming doctors that we need to find. We fail to then acknowledge the work that the current doctor, so the one, is still doing in the system. And with regards to single employment model, really there's a question that remains around what happens after fellowship. With regards to technology, really telemedicine has a bright future, but in the context of patient-reported measures, the trend is not necessarily so great. So there's some further work required with regards to acceptance, basically, of telemedicine. The sector, I'm looking forward to seeing the sector moving into the implementation part of the consensus statement and really to embrace multidisciplinary health teams. We know it's a good solution. We know it's another one that's difficult to put in place, perhaps partly because of funding models in place at the moment, but it is very strongly part of the future. And finally, with regards to governance, you know, I can't help but think that the original DPAs was actually very useful, but the current use of DPAs or similar levers is no longer what it intended to do. And really, finally, this blend or this blurring of the boundaries of the operations of some jurisdictions versus, or traditionally, the traditional boundaries, some jurisdictions needs to be worked out, and in particular, organizations should absolutely be responsible or accountable for their impact, in particular the social impact. And look, just one little plug to what we do. So Rural Health, for example, is an online platform. So for those interested in working together, we do have a platform. Thanks.
Well, thank you, Jan. And I think it's particularly relevant to explore innovative models of care in this area, and that work needs to continue. I'll now hand over to Martin for the question and answer session.
Thanks, Ian. Just to remind everyone, if you do have some questions, please enter them into the chat, and we'll see if we can get to them as part of this discussion. So, thanks, Ruth. Thanks, Brendan, and thanks, Jan, for some great presentations. Really, really thought-provoking. I did want to pick up on that theme that Ian just expressed at the end there about the role of technology. I mean, Jan, you talked a little bit about this in your presentation, as you all did, but I'm wondering if you all could share your views about what you see the potential of technological change for the rural health sector, how you see the role of things like telehealth and virtual care and other new models that are being developed with technology support, how you see them influencing the way care is delivered. And I think that important question that a few of you touched on about how acceptable that is to communities, and whether it's an example of perhaps the geographic narcissism that you were referring to before, Ruth. Like, how do we see the role of that sort of shift in delivery in rural health? Ruth, did you want to start us on that topic?
Yeah, I'd like to. Thanks. I've had two conversations this week that are really pertinent to that question, Martin. The first one was with a company that's working in one of the in the CBD of one of our major cities, and was very excited to contact me and seek my endorsement of some technology that they've developed to allow to enable holographic connection between remote communities, and and the idea they had was specialists in the big cities. And as I was listening, I was getting more and more uncomfortable, because they didn't once mention having had any conversations at all with remote communities and remote consumers. And my response to them was, this is great technology. It's a beautiful tool. I can really see it. But you need to talk to communities and find out what they want and how your tool might be able to help them achieve what they want to. This morning we had a webinar with the South Central Foundation, which is an Alaskan Native health service, and they were describing the way that they connect remote communities that can only be reached either by helicopter or boat when things have thawed a bit. And they, whilst they have 65,000 consumers in their service, about 30% of them are remote dwelling people. Their whole description of their model of care is that they have consumer owners, and the consumer owners define and determine what care will be received and the model of care. And so, yes, they use technology, they use telemedicine, and they use some pretty innovative stuff, such as a pharmacist in Anchorage can press a few buttons and a dispensing machine will dispense the medication that they want. They see a video play of the dispensed medication and can do the checks that they would normally do and watch the labels put on. You know, that's an example, and it meets an absolute need. And I think that the difference between those two stories is the crucial part. We need to respond to the need that the community has expressed and respond with a tool that will help them meet their need. Not turn up and say, look at this amazing bit of new equipment I've got. How can I sell it to you? No, they wouldn't put it like that, but that's really what they mean. Yeah.
Thanks, Ruth. Fantastic. I wonder if I could throw to you, Brendan. How's technology being considered in say the 10-year strategy that you described? What sort of role do you see it having moving forward?
I think this really fits into that example that I gave earlier on around great things that are happening across regional New South Wales. And look, to give credit to other states, there's a lot of great work that happens across the regional footprint across the Commonwealth. But in regional New South Wales, we've got some great examples of where virtual care is working very, very well. And if I use as one of those examples the model in Western New South Wales Local Health District with the hub based in Dubbo, and there are probably three key things that sit around that model. One is context. So each of the doctors that work as part of that model also spend a day inside of the sort of working fortnight out in one of the regional communities, so that they have context to the where people are at the other end of the service. And it's not to say that all doctors don't understand what it's like in a regional community, but context is really important from a regional perspective, and particularly in decision making. And I'm not a clinician, so don't just take my credit for it. This is me sort of feeding back from others. The second is support, and what we've seen is this, evolution of thinking around the role of positions like Aboriginal health practitioners, as an example from a cultural model perspective, playing a role as both the cultural support, but also though in some ways the pseudo clinical support and follow-up support for people who are connecting through virtual care. So that sort of person that's in community, in person, trusted because they've got those relationships, and then able to bridge that kind of tentative gap that people have, that nervousness sometimes. The third is about communication. This is, I think, what we've learned with virtual care and the conversations that we have with communities is that we can't tell communities this is what's good for them or this is what their option is. We have to engage communities in the decision making about what that service sort of looks like, and also over a period of time be open to the suggestions that community members give to us about how they'd like to be able to utilise that service. And I genuinely believe that New South Wales, particularly those local health districts with a lot of the remote communities, are making every effort to really come to that sort of those three areas that I've mentioned.
Thanks, Brendan. Jan, did you want to add anything to what the answers have been so far?
Well, it's really hard to add from the two key speakers, but look, very practically, there are places who screen for a doctor and to whom to screen for a solution, a predetermined solution, and to whom the discussion quickly lead to the conclusion that you will never get a doctor, never. So that is possibly a number of locations where technology will play a very key role. The second thing I would say is that the worst thing what we've learned that the worst thing we can do if in trying to find a solution is to come with a solution. It is very, very difficult to enter a room and to sit down with the right key stakeholders and to say, we haven't got a solution. Now our task is to design a solution. And there's a lot of sort of pull and push and opinions and experience and that occurs then, but it is very difficult to enter in a room where people are really desperate for a solution, saying we don't have a solution. But we will design it, but we don't have one yet.
Yeah.
And I think the approach is very the approach for solutions which are technology based is just as valuable I don't think we have done as much as sort of human solutions, but yes, I think that's the future, trying to find these solutions, to co-design these solutions.
Thanks. So I think the other theme that was pretty prominent in all of your presentations was around workforce, and we've also done some workforce work particularly with Indigenous communities, and learning a lot about the challenges that they're facing around their own well-being and their own support networks in their communities when they're offering so much to those communities. And I'm wondering if any of you would have some reflections on, once you have staff in place and once you have staff in rural communities established, what sort of support networks, what sort of structures do you think are needed out there for those positions to flourish and, I guess, be retained, but also more than just be retained, actually flourish in those communities and those environments? Anyone got some thoughts on that?
I think Ruth's going to go. I missed a bit of the question. Sorry, someone just walked into the room and saw some sort of random dark guy sitting in the room here on a video conference. But so I missed the first part. I'm sorry, Martin. So I'll let Ruth and Jan
sure.
step in.
Okay. Why don't you go ahead, Ruth? Yeah.
Okay. So I'll repeat the questions as I understand it, Martin. What do we know does actually work to attract workforce to rural and remote communities? Yeah.
I think as well. I think I'm interested in the retention aspect as well. Like once they are in place, what's the best support network? How does that function most effectively? Yeah.
It's interesting. There are some very simple things that that we know make a difference. I'm part of a as yet unpublished study of the decision points that James Cook Uni graduates have in deciding whether they'll stay or leave a rural community. And one of the things that came up in both the decision to stay and the decision to go was childcare. If it's there, they're much more likely to stay. If it's not there, they're much more likely to go. And I don't think communities or regional planners are taking that into account enough.
Mm.
So that's I've also been very impressed by the work of Kath Cosgrove for her PhD, that it's about community connectedness. Once you've got somebody there and they've been there for the first year, and that the decisions about do I stay during that first year are about the job. After that first year, it's about how connected am I to this community? Is this my community? Do I feel safe and welcomed here? And I can absolutely identify with that. Leaving our little community in southwest Victoria after 22 years, I was far less concerned about whether somebody could do the work than walking out on the connections that we had made. I still have, lingering, I still have regrets about breaking those relationships. Yeah.
So we are actually fast running out of time. Is there any quick reflections on this question from Brendan or Jan?
I wholeheartly agree with Ruth. So what we hear, and certainly a lot of the current evidence is around any of the communities that step into to this concierge type service where you might have local council and a number of other people playing a role in welcoming in a part of that recruitment and attraction process, and the complementary things that sit around the recruitment of a person to the facility, like introducing children to schools, finding the partner, a job, connecting to rentals or homes. And all this sounds like a lot of work, but the reality is if you want to get to the front of the queue with recruiting people, you need to play this sort of concierge role. It's not just health role alone, though, and this is where the smarter towns, I think, have picked up this thing that they need to do this with their collective partners. Wholeheartedly agree as well around the retention part, that quick integration into the community and people feeling like they're not this sort of weird alien in a town is really important, because we're funny people, us regional people, aren't we all? And we all know when there's someone that's new in a community, so it's sort of someone not feeling like they're being stared at. The part that we've heard from staff that was really important from a facility perspective is this rapid familiarisation with the model in the town. And so someone to actually take the time with a person when they start to really familiarise them with the way that the service is delivered in that community, because they're all different in their own subtle way. So how do you connect to virtual care? What sort of services are provided? Who are the people that are the other key kind of stakeholders in the community? Not this just whole turn up and then don't worry, you'll work it all out in a couple of weeks. So just, breathe through it approach. I'm not saying that people lack courage in the modern day. I'm just saying that people, if you want to sort of retain somebody, what's important is to get them sort of familiar with the way you deliver care. The other should come as no surprise, and that's professional development. In the need to want to recruit and retain people and to just get the work done. I think we really forget that it's important for anybody anywhere in any workforce to feel as though they've got good access to professional development, and that's the key that staff say that they don't feel like they're being professionally developed, and they just feel like they're being used.
Thanks, Brendan. There's two more questions that I want to get to, so we might move on to those. So there's one in the chat about women's health, and as distinct from, I don't know if you can all read that, but as distinct from obstetrics and sexual reproductive health, I think the question is about women's health, progress in women's health in relation to mental health and well-being and gender-based violence. And I'm wondering if any of you would like to comment on the progress in women's health in that area in rural communities.
I would say I don't know as much. Sorry, I'm going to jump in before Ruth, and only just because I believe in being humble and honest in terms of my own knowledge. I would say that I don't know enough about what's happening more broadly as much as what I should from a women's health perspective. But what I do know from my background in running Aboriginal health services, particularly in that Western and Far West New South Wales footprint, is that there is a real kind of growing of empowering professional Aboriginal women in our workforce, whether they be Aboriginal health workers or Aboriginal nurses, to take on, to run programs with a cultural concept or that sits behind the models that they deliver to support women across the footprint, regional communities. And we've seen significant increase in things like the programs like AMIS, that Aboriginal Maternal Infant Health Service, and the Building Stronger Foundations program, that's sort of that extension of birthing of Aboriginal children in support of Aboriginal mothers or babies of mothers of Aboriginal children. So not just Aboriginal mothers, but mothers of Aboriginal children. And I'm seeing that there's growing recognition that the best way to deliver that care is to have Aboriginal people in your service that actually deliver that. So I've seen that. I don't think, can I say that I don't think that there's enough that happens in terms of recognition of the way that we support communities in terms of domestic violence. And I think it's spoken about. There's certainly, an increased promotion of it, but I don't think there's enough that we probably do, if that makes sense. So I don't know if I'm supposed to say that, but it's just a general feeling.
So I think the last question I'd like to finish on, just hear from you all on, where do you think better evidence would be most beneficial to the rural health sort of agenda? Where would better evidence strengthen the case? What could be done to build the evidence base that would actually support your work and your roles? Is there anyone want to respond to that?
I'll jump in and try and keep it brief. I think, and by the way, Brendan, you answered that far better than I could, so thank you. I think that we need real rural researchers. So we need people who are engaged in the community, particularly rural clinicians who understand what the challenges are, but also rural consumers who understand what their challenges are, undertaking the research for a start. Yes, I really like to see strong collaboration between experienced urban researchers and rural researchers, but I like to see the agenda setting coming from the rural communities. And I particularly want to see a focus on translation of evidence into practice, because where we see that work, it's very often in an urban setting, and what challenges us very much in rural and remote clinical settings is, how do I do that here?
Yeah. Thanks, Ruth. Jan, do you want to go next?
Yeah, look, I couldn't agree more. I think, well, firstly, the enablers for that to happen are probably more present than they have ever been. I mean, just down to the boring stuff, there are now associated fields of research codes where institutions could claim actually a line of work in that space and report against it and perhaps get some prestige out of it. Look, I do. It's a very multifaceted issue. It's like asking the question, how do you fix health? Well, it is somewhat complicated. But I think what we probably would need first is a framework to do it. It's really, how are we going to tackle that beast sort of approach? There are already some very significant players in this space. There are already some very significant contributions. It's about capitalization. There cannot be rural health. So we call it health access work, but that's purely because this is the sort of it captures what we do. But there cannot be research without translation. These days have to be gone, and we lose folk. Rural people. They are very quick at telling you exactly where to go if they feel that your work is not effective, and there is a very significant component about impact. So it's really research for impact. Doesn't mean that everybody has to fix every problem, but every challenge. But it has to demonstrate impact. And hence my comments previously around social leadership.
Thanks, Jan. Any final thoughts, Brendan?
Yeah, I've got 4 really biased ones, so I'm just going to land them on you because I'll be really happy to have conversations with people about these and any others. But here's 4 of real interest to me when you ask that question. One, this thing around contemporary health service design, whether or not we really are truly designing contemporary health services, or if we are still hanging on to too much of this sort of traditional historical approach to the way that we design healthcare models in rural, regional, remote communities. So there's that. I don't know if that could be researched, but it's a question. Generalism is another one that I'm very interested in, and not just in the from general practice doctor medical perspective, but generalism, nursing, and a whole range of things. Very, very topical. And the other 2 interconnected. I don't see enough of the adoption of any of the learnings from rural, regional, remote research in the areas of public health and Aboriginal health. I think there are lots of people that actually do research pieces of work in this space. I know this from my previous role in Western New South Wales. I just don't see, though, where some of the learnings have been adopted by the healthcare system and that information be utilised to the benefit of communities. And I think there's this thing of how do we ensure that the information in its richness is shared with the system, and that the system uses that information to grow and improve.
Fantastic. Thank you, panelists, for a great discussion. I'll hand back to Ian now to wrap things up.
All right. Thank you, Martin. And first of all, to Ruth, Brendan and Jan, thank you very much for your presentations, high quality presentations. And I think we've learned something for next year, and that's that we should allow more time for the discussion, because it's very valuable discussion afterwards as well. I'd also like to thank all of our members for attending and for the questions that you ask. and particularly emphasise you did so well last year in picking the theme for this year. We'd be most grateful if you'd suggest themes and priorities for Sax forums and indeed for the colloquium in 2024, and we look forward to interacting with you next year. So thank you very much, and have a good summer break.
Thanks a lot.
Thank you.
Thanks, everyone. Bye.